A 55-year-old man walks into his GP clinic. He looks exhausted, not just tired, drained. He sits down and says, "I just don't feel like myself anymore." For the past few weeks, he's been increasingly fatigued. Even walking up a flight of stairs leaves him short of breath. He used to be active. Now he struggles with simple tasks. And then you see his blood test. Hemoglobin, 72. That's severely anemic. But one detail stands out. His red cells are abnormally large. So what's going on? Let's work through this case. Let's start with the history. He's 55, works an office job, and has no major past medical history. No recent bleeding, no black stools, no vomiting blood. That's important, because we need to rule out blood loss as a cause of anemia. His diet seems reasonable. He eats meat occasionally. But when you dig deeper, he mentions something subtle. Over the past few months, he's had numbness and tingling in his hands and feet, pins and needles, and more recently, he's felt slightly unsteady when walking. That should make you pause, because anemia alone doesn't usually cause neurological symptoms. So now pause. We have severe anemia, fatigue and shortness of breath, neurological symptoms, and large red blood cells. What's your differential? Let's move to examination. He looks pale. There's a slight yellowish tinge to his sclera. Not frank jaundice, but enough to notice his heart rate is elevated, around 105. That's a compensatory response to anemia. On examining his tongue, it looks smooth, glossy. This is glossitis. And on neurological exam, there's reduced vibration sense in his lower limbs. That's a key finding. So now we have a clearer picture. This isn't just anemia. This is anemia with neurological involvement. Let's look at the blood results in more detail. Hemoglobin, 72. MCV, mean corpuscular volume, 112. That's high. Normal is around 80 to 100. This is a macrocytic anemia. So now we classify. Anemia can be divided by MCV, microcytic, normocytic, macrocytic. This is macrocytic, and that narrows things down significantly. Macrocytic anemia can be split into two main categories, megaloblastic and non-megaloblastic. Megaloblastic anemia is caused by impaired DNA synthesis. The two most important causes, vitamin B12 deficiency, folate deficiency. Now here's the key question. Which one is it? Let's go back to the history. Neurological symptoms, that's the clue. Folate deficiency does not cause neurological symptoms. Vitamin B12 deficiency does. So already we're leaning strongly toward B12 deficiency. But let's confirm it. The blood film shows large red cells, macrocytes, and hypersegmented neutrophils. That's classic for megaloblastic anemia. Now we check B12 levels. They come back low. Diagnosis confirmed, vitamin B12 deficiency, but we're not done yet. Because now we need to ask, why? Common causes of B12 deficiency include poor dietary intake, especially in vegans, malabsorption, gastric surgery, and autoimmune conditions. In this patient, diet isn't the issue. So we think about absorption. Vitamin B12 absorption depends on something called intrinsic factor produced by the stomach. Without intrinsic factor, B12 cannot be absorbed in the terminal ileum. This brings us to the most likely diagnosis, pernicious anemia. Pernicious anemia is an autoimmune condition. The body produces antibodies against intrinsic factor, or the gastric parietal cells that produce it. Without intrinsic factor, B12 can't be absorbed, and over time, stores are depleted. Now, let's connect everything. Vitamin B12 is essential for DNA synthesis. Without it, cells can't divide properly. This affects rapidly dividing cells, especially in the bone marrow. So you get large immature red cells. That's why the MCV is high. But B12 also plays a role in myelin formation, which is why deficiency causes neurological symptoms. This is a key distinction from folate deficiency. If left untreated, these neurological changes can become permanent. That's why early diagnosis is critical. So how do we treat it? First, replace vitamin B12. But here's the key point. In pernicious anemia, oral B12 won't work effectively. Because absorption is impaired, so we give it intramuscularly, typically frequent injections initially, then maintenance doses long-term, often for life. In this patient, B12 injections were started. Within weeks, his energy improved, his hemoglobin began to rise, and, importantly, his neurological symptoms stabilized. Now, here's an important caution. If you give folate alone in someone with B12 deficiency, you may correct the anemia, but the neurological damage will continue. That's a classic exam trap. So always check B12 before treating folate deficiency. Let's summarize the key takeaways. 1. Macrocytic anemia. Think B12 or folate. 2. Neurological symptoms point strongly toward B12 deficiency. 3. Hypersegmented neutrophils are a key clue. 4. Pernicious anemia is an autoimmune cause of B12 deficiency. 5. Treat with intramuscular B12, not oral. This case wasn't just about fatigue. It was about recognizing patterns, linking symptoms across systems, and understanding the underlying physiology. And here's your next case. A young man presents with sudden chest pain and shortness of breath after a long flight. What's the diagnosis? I'll walk you through it in the next video.